Hello everyone. Today I shall discuss with you the role of beta blockers in heart failure and difference between metoprolol succinate and metoprolol tartarate and what is the clinical relevance of this difference. As such, use of beta blockers in heart failure and after myocardial infarction has been since last 50 years, and the role of beta blockers is well established in heart failure management. Among the beta blockers, initially there was propranolol and atenolol which were used after myocardial infarction. Later on, bisoprolol, carvedilol, metoprolol, nebivolol have been well studied for treatment of heart failure with reduced ejection fraction in large multicentric trials, so much so that these four drugs are now well established in the management of heart failure as per the guidelines. Now, beta blockers are beneficial in heart failure because heart failure is characterized by changes, and these changes include gradual development of the structural and functional adaptive changes which are collectively known as heart failure gene program. Now, this gene program is characterized by downregulation of beta-adrenergic receptor density, upregulation of inhibitory G proteins, decreases of sarcoplasmic calcium ATPase activity, and the first isoform of myosin heavy chain. Along with, there is also a change in the repolarizing potassium currents that lead to poor cardiac function ultimately and arrhythmogenesis. Beta blockers reverse these changes of heart failure gene program by antagonizing the cardiotoxic effects of catecholamines and by causing upregulation of myocardial beta receptors, reducing RAS activity, which is actually hyperactive. So there is a reduction in the structure in the effects of the angiotensin II and also the effects of endothelin system. There is improvement in the coronary flow with reduction in the heart rate, blood pressure, and arrhythmias. Blockers are very effective. Now, these beneficial effects are seen in the form of gradual attainment of the beta blockade will contribute to paradoxical increase in the left ventricular ejection fraction after months of treatment. There is improvement in the New York Heart Association class, so class 3 becomes class 2, remarkable reduction in the all-cause mortality in heart failure cases and the rate of arrhythmogenic sudden death. And these changes are noted in large-scale multicentric trials, particularly when beta blockers are used for 1 year or more in patients with heart failure with reduced ejection fraction with or without ischemic heart disease, that is myocardial infarction also. Now, currently, beta blockers are one of the four pillars of the heart failure management. Pillars being beta blockers, ACE inhibitors, ARBs or ARNIs, that is sacubitril, mineralocorticoid antagonists, spironolactone, eplerenone, and SGLT2 inhibitors, that is very important drugs, empagliflozin and canagliflozin. While salutary beneficial effects of these agents, that is beta blockers, in heart failure is considered as a class effect, but there is a growing evidence to show that individual pharmacokinetic and pharmacodynamic characteristics play important role in showing relative difference in the efficacy with different beta. So it appears to be class effect but is driven by individual characteristics of the drug. Now, effectiveness and safety of the four different beta blockers was studied from 14 randomized controlled trials. It was reviewed and in summary it was found relatively Bisoprolol showed superior benefit and similar safety in heart failure as compared with carvedilol. One. Second, compared with metoprolol succinate, bisoprolol did not significantly decrease all-cause mortality but decreased readmission rates. Third, metoprolol succinate and carvedilol have similar evidence in the treatment of heart failure so far as efficacy and safety are concerned. Fourth, carvedilol provides more benefit than metoprolol tartrate in the treatment of heart failure with a similar safety profile. Nebivolol shows similar benefits and safety profile to carvedilol. To sum up, the evidence shows that efficacy and safety of bisoprolol is more than carvedilol, which is equal to metoprolol succinate and which is equal to nebivolol, but nebivolol shows more effect than metoprolol tartrate. Now, in this relative efficacy and safety, metoprolol tartrate stands at the lowest grade. Although at present head-to-head comparisons of metoprolol versus metoprolol tartrate versus metoprolol succinate in large-scale multicentric trials for heart failure treatment are lacking and they are needed. So, why are these differences? These differences are perhaps because of differences in the pharmacokinetic, pharmacodynamic, and pharmaceutical factors related to individual drug. I will focus on large third point, that is pharmaceutical alteration, and we will later on know that some drugs are available in different salts and or esters, and these esters may show differential activity. However, it has been proved that whether a beta blocker is cardioselective or not, or it has additional properties, it will definitely show benefits in the heart failure. Metoprolol is the most commonly used beta blocker in heart failure and after myocardial infarction to prolong survival. It is cardioselective with moderate lipid solubility, negligible membrane stabilizing activity, and about 50% orally bioavailable. Now it is extensively metabolized by cytochrome oxidase 2d6, and genoform variations will result in a wide variation in its plasma levels. In general, half-life is 3 to 4 hours, but maybe 7 to 8 hours in poor metabolites, and that may ultimately affect the efficacy. Standard uses of beta blockers, particularly metoprolol, hypertension, heart failure, particularly with reduced ejection fraction after myocardial infarction, treatment management of angina pectoris, vasovagal syncope, functional tachycardia, migraine prophylaxis in place of propranolol or temolol, and thyrotoxicos. Now there are two formulations of metoprolol. One is metoprolol tartrate, which is immediate release but is also available as sustained release. One tablet contains 25 milligram or 50 milligram or 100 milligram or 200 milligram. This other salt is metoprolol succinate. Now this succinate salt is always available as sustained release tablet. Now the succinate tablet or capsule contains 23.75 milligram, 47.5 milligram, 95 milligram or 190 milligram, and these doses, although are lower than metoprolol tartrate, but are considered to be bioequivalent to 25 milligram, 50 milligram, 100 milligram and 200 milligram of metoprolol tartrate. One may compare molecular weight of each. Now, metoprolol sustained release is a specialized formulation dosage form. The tablet is available as a multi-layer tablet with many units of controlled release pellets within, and each pellet acts as a separate drug delivery system or unit. The active drug in the pellets is coated with a polymeric membrane, ethyl cellulose, and after ingestion, the tablet disintegrates into individual pellets, and each pellet acts as a diffusion unit, releasing the drug at a relatively constant rate over a period of 20 hours. What does it mean? It means that the release is slow and sustained, independent of luminal pH, gut motility, and food. It is zero order release kinetics, just like we studied zero order release kinetics in some of the TTS patches. Thus, metoprolol succinate produces sustained blood levels over 20 hours to 24 hours with less variation in the peak to trough blood concentrations. Therefore, these variations are always less than half to one-third of those seen with metoprolol. Now, Cook et al. Compared the hemodynamics between two doses of metoprolol tartrate with one dose of succinate in a small number of cases with heart failure. The study was for 3 months, and it has been shown that ejection fraction increased 10 to 11% with both drugs with no difference. However, the study also demonstrated that it was safe to initiate metoprolol succinate at a dose of equivalent 25 mg and rapidly uptitrated over a period of 2 to 3 weeks as compared with the conventional initiation of a smaller metoprolol tartrate 6.25 mg BD and gradually uptitration over a period of 4 to 6 weeks time. So it was the benefit of using metoprolol once daily versus metoprolol tartrate. Now there are a lot of the differences in pharmacokinetics and which can be seen summarized in the tables. Water solubility: tartrate salt is more water soluble than succinate. Duration of the action and dose: duration of action of the metoprolol is shorter, so it is need to be given at least twice daily, whereas metoprolol succinate will be given once daily. Bioavailability is 50% for metoprolol and is 40% for metoprolol succinate. And food increases bioavailability of metoprolol tartrate only, and the absorption and bioavailability is independent of food because it obeys zero order release kinetics metoprolol succinate. Peak to trough plasma ratios are much higher even with twice daily doses of metoprolol tartrate, whereas such variations are half to one-third of metoprolol tartrate when metoprolol succinate is used. Half-life of metoprolol succinate is much longer than metoprolol tartrate. Even metoprolol tartrate SR has a half-life of 4 to 5 hours only. And dose proportionality kinetics are very important to differentiate that the metoprolol tartrate absorption and bioavailability is saturable. Because of pre-systemic metabolism is saturable, this will lead to disproportionate rise in the blood levels after increasing doses. And this dose proportionality is not seen as such with the metoprolol succinate, and therefore disproportionate rise does not occur and there is no variation in the peak and volume of distribution is again different. It is higher, little higher with succinate salt. Protein binding is almost similar. Excretion is much less with both the drugs. Mostly they are excreted as metabolite. And in hepatic impairment, because pre-systemic elimination of tartrate salt is reduced, so its bioavailability will be increased. However, such change will not be seen with metoprolol succinate. Beta 1 selectivity: variable levels in the peak and trough with the metoprolol tartrate may achieve very high levels sometimes, which may also block beta 2. And this will not be seen with metoprolol succinate because sustained levels are there. Therefore, Beta blockade is more sustained, beta 1 particularly, with succinate versus. Finally, approved indications, FDA approved indications for tartrate are hypertension, angina, arrhythmia, post-MI, and rate control in atrial fibrillation, whereas approved indications are hypertension, angina, heart failure. Because in heart failure, succinate salt has been shown to reduce all-cause mortality rate by 34%. Used in acute MI, injectable form of tartrate is available, which has been used to reduce infarct size and reduce infarct-related reperfusion injury. Therefore, long-term improvement in ejection fraction is expected. Whereas metoprolol succinate is not used injectable but is used only for long-term maintenance therapy. Now, usual maintenance doses are comparable, but because of differing bioequivalence, little smaller doses are needed for metoprolol succinate. However, it is given once daily. Now, in pediatric hypertension, FDA doesn't approve metoprolol tartrate, but metoprolol succinate has been approved. Now, level of evidence of efficacy in heart failure is low, tartrate, high, metoprolol succinate. Now, important precaution is that unformulated short-acting drugs should always be avoided in ISD, whereas sustained release levels are achieved. Therefore, succinate salt can be used in these conditions. In one study, it is the metoprolol succinate in a large landmark study called as Merit Heart Failure Trial. It has been shown that metoprolol succinate reduced sudden death by 41%, all-cause mortality by 34%, and hospitalization by 31%. The actually trial was terminated prematurely at 1 year rather than 3 years to provide benefits to all. Recently, benefits of metoprolol succinate treatment were shown in patients with acute MI who underwent revascularization procedure, and the benefits were receiving and those receiving oral sustained release metoprolol succinate showed a reduction in the 3-year risk of major adverse cardiac events by 7.1% more than their counterparts who received observation only. Particularly, the risk of recurrent myocardial infarction and revascularization was reduced. This benefit was seen even in lower doses of 47.4 mg, 5 mg metoprolol succinate. Now, this is one study which is done in the post-revascularization era, whereas the merit efforts done during pre-vascularization, percutaneous vascularization, angioplasty era. Therefore, differences are also remarkable. Now, the current study additionally observed that the effectiveness of receiving metoprolol succinate treatment in subgroups of ejection fraction more than 50% with normal BNP levels. That means heart failure with preserved ejection fraction and normal BNP levels also benefit from low dose metoprolol therapy. And long-term use has been also shown with beta blockers with myocardial infarction. Tartrate has been shown to reduce infarct size, but it is not preferred for long time. But succinate salt is currently used for long-term treatment after myocardial infarction. It has been shown, as seen earlier, to improve survival and increase left ventricular ejection fraction. However, at present it is not known that post-MI patients with preserved left ventricular function may benefit from long-term prophylaxis beyond 3 years. And there is a risk of new onset diabetes and long-term beneficial role in post-reperfusion era remains to be determined, although it is being evaluated. So, metoprolol succinate used in peri-procedure period is a recent study, and this study was conducted on those patients who suffered peri-procedural myocardial infarction during PCI procedure, and they were followed for 3 years mean duration. Metoprolol succinate recipients were found to have reduced subsequent 3-year risk of major adverse cardiovascular events, including myocardial infarction, sudden death, stroke, and revascularization, by nearly 7.1%. Additionally, logistic regression analysis showed that receiving metoprolol reduced the risk of myocardial infarction. Therefore, we can say that although beta blocker benefits are class effect, but the species changes, the changes in the pharmacokinetics due to formulations determine the better efficacy of metoprolol tartrate as better efficacy of metoprolol succinate as compared to metoprolol tartrate, and therefore today metoprolol succinate is the most commonly used beta blocker for the long-term treatment of chronic heart failure with or without reduced ejection fraction and following myocardial infarction. Thank you. Some of the references, the relevance.